It's a pleasure to be with you. The title of this session is Practical Epidemiology Introduction, Session 2. There are no disclosures for this presentation. The objectives for this session include briefly review epidemiologic skills, discuss basic communications concepts, review the uses of epidemiology, and review epidemiologic ethics principles. This slide lists basic skills that a good epidemiologist must possess, including interdisciplinary approach, use of the scientific method and critical thinking, including reasoning, deduction, and problem solving, quantitative and computer skills, and communications skills. Epidemiologic work often taps into many other disciplines, including biostatistics, analyzing numbers, history, previous accounts of diseases, sociology, determinants of health, demography and geography, location of populations, diseases and risk factors, behavioral sciences, why and how people act, and law, policy impacts. This doesn't mean an epidemiologist is an expert in all of these fields, but needs to know when and how to access these areas as appropriate for the situation. A good epidemiologist must be able to assemble, facilitate, and work with experts from many disciplines and ultimately pull it all together, making sense of very complex situations. The field of public health can't survive without epidemiology. It is a core set of competencies and skills for the field. Scientific method, or critical thinking, is a systematic approach to data collection and analysis. The scientific method is objective and based on data, which is sometimes a challenge for public health scientists and epidemiologists when working with some politicians who in that role may lean toward the subjective, often responding more to an emotional story, testimonial, complaint, or experience of a constituent than scientific, objective data when developing policies. So why would a politician think and act that way? Let's spend a few minutes discussing culture shock. Culture shock doesn't just occur when living and working outside the United States. It can occur whenever two cultures or subcultures clash over differences in one or more 7 dimensions of cultural distance, including 1. Worldview, ways of believing, 2. Cognition, ways of thinking, 3. Linguistic forms, ways of expressing ideas, 4. Behavioral patterns, ways of acting, 5. Social interactions, ways of interacting, 6. Media influences, ways of channeling messages, and 7. Motivational resources, ways of deciding. The more one culture or subculture differs from another in these 7 dimensions, the greater the cultural distance and resultant difficulty understanding each other and communicating between those cultures. This slide lists some basic diagnostic questions that help us understand whether we're in a cross-cultural communication situation. Do we use a different language than the group we're trying to communicate with? That doesn't just mean obvious differences. I speak French and the other group speaks Spanish. Do we have a common vocabulary? In the health field, we commonly use terms and words unknown to other groups who may be from the same culture but of a different subculture. This is enhanced with folks from other racial and ethnic backgrounds. Do we have a different meaning in our heads than the person we're trying to communicate with? In the health field, absolutely. Otherwise, we wouldn't need to use health messages at all. They'd already know what to do. Do we ever get frustrated when people don't change their risky behaviors or policymakers don't craft policies based on good scientific data after having heard our message? Makes perfect sense to us according to our way of thinking. If you answer yes to those questions, you are suffering from a condition called culture shock. Not understanding how people could be so ignorant or stubborn to not respond appropriately despite knowing what's right, at least from our perspective. You just told them what to do and they didn't change. We've all been there, and most of us are still there. Did we ever consider that maybe our message isn't coming across as well as it should because we are actually in a cross-cultural situation? Many public health scientists have been in a state of culture shock for years and don't recognize it. We could spend a lot of time talking about cultural distance between scientists and politicians, but let's focus on the cognition dimension for a few minutes. A detailed discussion of these dimensions, along with other issues, are covered extensively in the North Dakota Public Health Training Network Community Engagement course. Back to our question. So why would a politician think and act that way? The scientific data was so clear. Ways of thinking are often quite different between cultures and subcultures and can impact cross-cultural communications. There are generally three categories of thinking or cognition, including 1, conceptual, data and facts, 2, relationship, social interaction, and 3, psychical, mystical, spiritual, inner experience. All three categories are used in every culture and subculture, yet there are often differences in category emphasis or priority. This category emphasis or priority is formed from our worldview or deep beliefs and values. Some cultures set their first cognitive priority as concepts, others relationships, still others cyclical thought. Western cultures and scientists generally represent conceptual thinkers. Even though relationships are considered concepts, data and facts are the priority. The cyclical is often marginal to conceptual thinkers. The majority of epidemiologists in their role as public health scientists are conceptual thinkers. What the data shows is most important. Data is more important than relationships and cyclical or mystical cognition. Eastern cultures, tribal groups, and politicians in their role as a member of the subculture of politicians most often represent relationship thinkers. Concepts are often secondary, with the cyclical marginalized. Indian subcontinent cultures and strong faith-based communities represent cyclical thinkers. The mystical, spiritual, and inner experience predominates, with relationships being secondary and concepts marginalized. The order of priority can vary with the culture and subculture and can be a source of confusion during cross-cultural communications. Understanding and utilizing the cognitive priority of the target community is essential for appropriate communication strategies, from an epidemiologist as a conceptual thinker to a politician prioritizing relationships. The way we prioritize our cognition as conceptual thinkers focusing on data may not move relationship and cyclical thinkers. Understanding and utilizing the cognitive priority of the target community is essential for cross-cultural communicators. During legislative sessions, epidemiologists and other scientists commonly present well-prepared scientific data to policymakers. Yet in many instances, their presentation message seems to bounce off, as illustrated on this slide. In those situations, scientists often feel they didn't present enough data, subsequently inundate politicians with more data, tables, and scientific research, which still doesn't work, since relationship thinkers have a different cognitive priority and worldview. Cultural distance in this cognitive dimension can and often erupts as a cultural clash with emotions running high, resulting in tension, frustration, anger, accusations, etc. Each subculture feels the way they think, feel, and believe is the way to think, feel, and believe, and the other side is obviously wrong. Cross-cultural communications experts would advise that conceptual thinkers, like scientists, would likely be more successful if they would craft their message with the politician's relationship cognitive priority in mind. For politicians, relationships and social interaction are very important versus scientific data. A compelling story is often extremely effective with politicians and other relationship cultures. It would be nice if politicians would reciprocate more. It can and does happen. Yet during legislative sessions, scientists are entering the world and culture of the politician. In that setting, scientists need to take the initiative to appropriately craft messages to the politician's cognitive priority. The scientific method commonly uses 4 study designs, including cross-sectional studies, where the study group is selected without reference to either a dependent or independent variable; ecologic designs, studies of risk-modifying factors on health or other outcomes based on populations defined either geographically or temporally, where both risk-modifying factors and outcomes are averaged for the populations in each geographical or temporal unit and then compared using standard statistical methods. Case control studies, where the study group is selected based on the dependent variable like certain disease or conditions, and cohort studies, where the study group is selected based on the independent variable, the suspected causal factor or characteristic. These various study designs will be covered in more detail in future epidemiologic sessions. Computer skills are essential for epidemiology. This slide lists various computer analytic products currently available, including SAS, Statistical Analysis System. SAS was developed by North Carolina State University in 1976, and SAS is now up to version 9.0 as of 2013. Other analytic products include Stata, SPSS, Revolution Analytics, and Alpine Data Labs. SAS still seems to be the best. We've already touched on this briefly related to the cognitive dimension of cultural distance, but want to re-emphasize the importance of good communication skills. Epidemiologists need to talk with department leadership, politicians, the public, and the press. This equation states that all the good data and analysis will not be effective if an epidemiologist is not able to appropriately communicate that data and its implications to others. Without good communications, there will be no or inadequate changes in the behavior of others. We see that communication gap in public health practice at the state and local level across the United States. Why do we have problems with communications? This may be partly due to the limited coursework devoted to communications during the formal training of epidemiologists, or current deficiencies of public health workforce development curricula. Let's touch on a few basic concepts of communications that will be covered in more detail in the communications curricular sessions of the North Dakota Public Health Training Network. A main objective of communications is to transfer accurate meanings from a source to a respondent. The source must choose an appropriate medium: public service announcements, lecture, newspaper ad, radio or television spot, billboard, etc., to deliver a message that adequately represents the meaning to be transferred. The message is then encoded and delivered. The respondent then decodes the message. The respondent decodes the message by selectively choosing applicable bits of information, a bit management process, stored in his or her brain regarding that topic, and by some mechanism creates a meaning. Those stored bits of information that have been gathered throughout life and are often of variable quality, some good, some bad, no matter the quality, this is the information the respondent has to work with to create meanings. Each individual develops and utilizes a personally unique creative process to develop meanings, influenced by culture, environmental factors, and experience. A main point is that the ultimate meaning that influences the respondent is generated within the respondent. With that in mind, it's wise for epidemiologists and other public health scientists to focus not only on crafting good messages, but even more so on how that message is or will be decoded in the respondent. In other words, good communicators need to be respondent-oriented. It's not just about crafting a message that reflects our perspective of the information we want to deliver. We need information about how our respondents will process, interpret, and decode that message. That makes communications a bit more complicated. Feedback takes several forms, including verbal and various nonverbal communications like body language. A good communicator or message source listens to all forms of feedback and adapts the message as necessary to more effectively create appropriate meanings in the respondent. Approximately 65% of all human communication takes place in the nonverbal realm. The whole communication process takes place in the presence of noise. Noise is anything that inhibits the appropriate transfer of messages and meaning to respondents. Obvious examples include street sounds, room temperature, and idiosyncratic behaviors of the speaker. Other sources of noise include conflicting messages by opponents and politics. Another important aspect of the communication process is the context, which relates to making concepts relevant in a given situation. This idea of appropriate context is often related to being in the sweet spot. This diagram is adapted from Peter Sandman's book, Responding to Community Outrage. We won't cover this in detail. There are two scales: the horizontal axis, hazard, from low to high, and the vertical axis, amount of concern, from no concern to outrage. The blue circle represents the area of low concern and low hazard. This is the area called paradise. No problems. All of us would like to have jobs that were problemless, but that's not reality. In public health, we commonly find ourselves elsewhere on this chart. The red circle is the area of high outrage and low hazard. SARS and the anthrax scare in 2001 would be good examples of this. There are elements of emotion and irrationality in this area of outrage. In these situations, a person needs outrage management skills. Statistics are generally not the answer in outrage. A different approach is required, a more human, feeling, and understanding attitude. That sometimes is difficult for scientists who are driven by facts and data. When scientists respond with statistics in outrage situations, they're considered unfeeling and cold. In outrage situations, it's often best to say things like, "I hear your anger and concern. I'm here to help in any way I can. We'll get through this." The maroon circle represents a true crisis with high outrage and hazard. In these situations, a person needs classic crisis management skills. The green circle represents the area of public apathy, where we find relatively high hazard and low concern. Chronic diseases and injury prevention commonly finds itself in the area of public apathy. In this situation, we need strategies to increase the concern factor, to move the arrow to the sweet spot where people are adequately concerned and stimulated to a rational, effective response that results in the changing of high-risk behaviors. This approach often requires a source being more opportunistic to capitalize on the sweet spot window of time. A message at other times, no matter how well crafted, may not be as effective as desired. Let's consider an historical example of contextualization of public health messaging. This slide represents the concern level of people in North Dakota regarding West Nile virus around 2003. Up until the summer of 2003, there was no interest in West Nile virus. Public health messaged regularly in the winter and early spring of 2002 and 2003, but the public or press were just not interested in West Nile virus. In the mid to late summer of 2003, with increased human cases and a few deaths, the interest of the public was definitely elevated to the sweet spot. At that time, every public health message on West Nile ended up in the paper or on a television news spot. The health department had to establish a phone bank to adequately answer the deluge of West Nile questions. This was a prime time for West Nile virus preventive messages. Public health needs to be more opportunistic, capitalizing on times when our public is in the sweet spot. When former President Clinton had his coronary artery bypass graft procedure, public health had a small window of opportunity to message on cardiovascular health. That unfortunately didn't happen. A message delivered when respondents are not in the sweet spot may not be very effective. The last point on this diagram is cultural distance, defined by the 7 dimensions we previously briefly discussed. Once again, those 7 dimensions of cultural distance include worldview or deep beliefs and values, cognition or ways of thinking, linguistic forms or ways of expressing ideas, behavioral patterns or ways of acting, social interactions or ways of interacting, media influences or ways of channeling messages, and motivational resources or ways of deciding. Once again, the more one culture differs from another in these 7 dimensions, the greater the cultural distance and resultant difficulty communicating between those cultures. This is the last slide on communications concepts. Viggo B. Sogard described 4 message filters respondents use during the decoding process, including exposure to the message, attention of the respondent, comprehension, and retention. Exposure to the message relates to the appropriateness of the message channel used and the frequency of the message. Attention of the respondent correlates to noise, interest, and other distractions through the whole communications model. Comprehension corresponds to the respondent's ability to understand the terminology used in the message and create accurate meaning. Retention is associated with the respondent's assignment of importance to message meaning after having passed through the other 3 message filters. The goal of any communicator is to increase the accuracy of all 4 message filters to increase the transmission of messages and ultimately appropriate meaning to respondents. These basic communications concepts are important for epidemiologists and other public health scientists to consider when developing and delivering messages. So why is epidemiology important in public health? Public health needs to answer important questions based on science. Epidemiology helps us practically respond to questions like these. How can we prevent congenital Zika in our state? How much risk is there for an avian flu pandemic this year? What is the current status of the Ebola situation in the world? How can we prevent a measles epidemic in our local area and state? Does every college student need meningococcal B vaccine? How much of a problem is obesity in our state? Where should we focus efforts to control opioid misuse? Do we have problems with behavioral health in our local area and state? Let's look at a few practical examples of how epidemiologic data was used. This map summarizes influenza-type data from select countries from around the world in August 2010, as the United States was preparing for the 2010-2011 influenza season. Australia, Chile, Ghana, Thailand, and New Zealand still had significant H1N1, with China running around 20% H1N1. H3N2 is increasing in Chile, Kenya, and China. The United States often reflects the Asia experience, therefore expected a decline in H1N1 and likely an increase in H3N2 during the 2010-2011 seasons. CDC surveillance during the 2010 to 2011 season demonstrated that expectation. A decline of H1N1 from 52% to 25% of cases, and an increase of H3N2 from 0% to 46%, mimicking the epidemiology of China, which is not uncommon. This is the World Health Organization's report on Ebola cases in West Africa for March 2016. Guinea was the only country having cases, 2 from March 20th and 2 from March 27th. Does that sound bad, since there had been no cases for nearly 2 months? This is where judgment comes in. Analysis of epidemiologic data and considering other information like adequate control measures for new cases, the public health Ebola emergency in West Africa was declared over as of December 29th, 2015. This underlines the importance of not only data, but also appropriate analysis and interpretation of that data, along with consideration of all other interdisciplinary issues like clinical response and disease control infrastructures to make appropriate decisions regarding an epidemic. Guinea, Sierra Leone, and Liberia continue to meet criteria for interruption of original chains of transmission. These 4 cases listed in this table were not felt to be part of the epidemic, but represent an underlying endemic rate for Ebola in West Africa. This slide summarizes a major outbreak of hepatitis C in a Minot, North Dakota long-term care facility. 48 cases of the same quasi-species were identified. The median age was 83.5, with 62% females. An epidemiologic study of this epidemic was completed from 2011 to 2013 by the CDC and Department of Health. Results of the study included: no single exposure was identified. There was no evidence of drug diversion. Drug diversion was initially considered due to a recent hepatitis C epidemic in New Hampshire, proven to be due to drug diversion. Careful epidemiologic investigation eliminated drug diversion in this situation. There was strong epidemiologic evidence linking lax infection control measures associated with foot care and phlebotomy. Infection control retraining was instituted immediately and quickly controlled the epidemic. The work of epidemiology informs all aspects of public health and healthcare programs and strategies, including support evaluation strategies, formative process and outcome, inform programs both internal and external to departments of public health, health promotion, disease control, environmental and healthcare facility regulation, emergency preparedness and response, community engagement, healthcare, health education, support needs assessment processes, national, state, and local or community, and inform health policy both internally and externally. J.N. Morris described principal uses of epidemiology, including historical uses to study the history of health in a population, community health to help diagnose the health and wellness of a community through community health assessments. Health services, for example, to identify shortage areas or use epidemiologic data to help develop effective disease management services. Risk assessment, to estimate individual and aggregate risks of disease, accidents, and other health issues. The definition of risk in epidemiology is the probability that an event will occur within a stated period of time. The last of Morris's list is disease causality, using research data to determine the etiology of diseases. Seeing that epidemiology deals with the data of people, both individuals and aggregated, guidance for handling of that data, particularly with regards to epidemiologic research, is important, an issue of ethics. The definition of research is the systematic investigation into and study of materials and sources in order to establish facts and reach new conclusions. New conclusions are key words in that definition, adding new information to a field of study. The 5 bullets on this slide are the ethics guidelines for epidemiologists developed by the American College of Epidemiologists and includes minimizing risk and protecting the welfare of research subjects, obtaining informed consent of participants, submitting proposed studies for ethical review, maintaining public trust, and meeting obligations to communities. Assuring appropriate ethical research is the role of institutional review boards, IRBs, that need to review all human research projects. Appropriate communication and engagement of communities will foster community trust and ensure that their expectations and concerns are being met. It's good to remember that public health departments and their epidemiologists work for the populations they serve, not research institutions. In summary, epidemiology is interdisciplinary, utilizing biostatistics, history, sociology, demography, geography, behavioral science, and law. The discipline of public health relies heavily on epidemiology. To change risky behaviors, epidemiologists must effectively communicate. The main goal of effective communication is the transfer of meaning, not just messages, to respondents. Public health must ethically utilize public health data.